you're going to be able to review if you need it, and you're going to be able to share this presentation to your colleagues if you think they can benefit from all of this information. Tomorrow we have on the Dr. Anderson's morphology a very nice presentation. We are going to talk about the definition of hypoplastic left heart syndrome. I have the honor to present a case from my center, from Syria Medicine. And on the top of this, we are going to discuss the morphology and the classification of hypoplastic left heart syndrome. We are going to have a very nice guests, including Dr. Norman Silverman, who is here with us. So please don't miss this tomorrow. And then next Thursday, on January 21st, we are going to have a very, very nice webinar about the state of art of heart failure in children. We are going to talk from the etiology to medical management, to VADS, and to transplantation. So this is going to be a very, very nice webinar. Is going to be a big one, so please save the date. It's going to be on the 21st at 10 a.m. East, 4 p.m. European time. Please join us next Thursday. And now we are going to start our first webinar of the fetal. Sorry, my computer doesn't work well. Anyhow, we are going to start our first webinar of the series that Dr. Rima Badr from Saudi Arabia is preparing for us. She's the coordinator of the series, and she's going to talk a little bit about how the series is going to be. Rima.
Thank you very much. I'm very grateful to the Congenital Heart Academy for really teaching the world. And I'm also grateful to Corona for allowing us to come together without boundaries, without passwords. The idea of the fetal webinars is to add to the flavor of congenital heart disease. And as we all know that the fetal hearts is the origin of congenital heart disease. So I think if we look at it, and we plan to go to 3 levels, basic, intermediate, and advanced in each session. Today we have 3 great leaders in the field of fetal cardiology, and I'm sure the last webinar was also beautiful with Dr. Lisa Homburger and Dr. James Huta and Dr. Afra Muhammad. So we're continuing along the lines, and if you'd allow me, I'll introduce the first speaker. Are we on time, Grace? Okay, so the first speaker is the master of everything. I think I cannot really say more to Dr. Silverman, and we met many years back, and I had the honor of visiting him in Stanford and doing some research with him as well, and have some training. Dr. Silverman taught us a lot about fetal morphology, translunar echo. He has a bit of everything. And he has lots of titles and lots of research. So I really can say more than that he's the master of lots of stuff. Dr. Silverman, could you please start the first talk?
Thank you. Thank you very much, Rima. Can you all hear me?
Yes.
Yes, very well.
Okay. Share. Good morning. Well, thank you for that kind introduction. In our saying, it is what you've described me as a jack of all trades, and the rest of that is jack of all trades, master of none. So perhaps I could take that, and certainly as my...
This is cardiology. It's only one trade. The trade is cardiology, pediatric cardiology. So.
Okay. Well, as time goes by, we can see that, as we see from today's panel, that there are currently new masters in the field. So I'll just begin by looking at isomerism, and I'd like to can you all see my screen? We'll talk about what's new in isomerism. Well, first of all, when we talk about isomerism, almost everybody understands this as heterotaxy. And heteros is Greek for other than, and taxis is arrangement. So it's a loss of orderly arrangement of the body's asymmetry. It is neither situs solutus nor situs inversus. And really what it is described in its full length as visceroatrial heterotaxy. I have included some references that you might want to look up on these various interesting subjects. So first of all, let's talk about left-right asymmetry and patterning, and let's discuss the genetic influences. I got this slide from a friend of mine, Bruno Marino, published a paper on the symmetry of the snail, a sea slug. The sea slug, if you believe in evolutionary theory, has been with us for 600 million years. It's a very old structure. And if you fiddle with the normal pattern by knocking out a particular gene, the pattern becomes symmetrical in the opposite direction. In other words, an inverse of this pattern. And of course, this is under genetic control and can be seen as early as the morula of the mammalian placenta. So the gene that is involved in this is another nodal signaling gene called nodal, and it produces left-right asymmetry in snails. Now, we have to start going back a little bit further, and there are two new papers that have been discussed this syndrome very clearly, called Classifying Heterotaxy Syndromes, an editorial by Dr. Stephen Sanders and Tal Gaver, and I'm going to show that below, and then a great paper by Dian Yim and Sijin Yu and his other colleagues from the Children's Hospital Sick Kids in Toronto. So here is an example of the embryonic disc, a cartoon, and we see the primitive node and the primitive streak, and we see that cells migrate in this primitive streak in various ways, and this is at gastrulation, and it's modal cilia at the pit of the node that's over here. Okay, and they establish a flow of extracellular fluid across the node from right to left. This stimulates receptor cilia at the left edge of the node, initiating a transcription cascade that instructs the left lateral plate to generate left-sided structures. Right-sided structures appear to develop by default. For such a fundamental process, the left-right axis establishment is remarkably complicated, with multi-element effector receptor cells leading to the expression of distinct chains of gene products on either side of the embryo, and consequently, as we have understood from the syndrome, the variability in heterotaxy syndromes is well recognized. We need to move past the reliance of atrial appendage morphology or splenic status to develop a new paradigm for classifying the patients with heterotaxy based on biological and novel imaging biomarkers. And all of this was certainly about the problems with morphology described in this paper by Lim. So if you look at this here, here's a cartoon showing the monocilial elements at the node and the flow from right to left. Here's the primitive pit and the primitive node, and another cartoon showing the same. And of course, this has now been validated by scanning electron microscopy and other techniques. Now, one of the common causes of asymmetry is the ciliopathies, such as primary ciliary dyskinesia. And this is a patient who was scanned, had a nasal biopsy. And you can see over here, I think very clearly, the ciliary motility on this nasal mucosal cell, flapping and of course moving the mucus across the surface of the cell. Now on the right is a patient with primary ciliary dyskinesia. And I don't know whether the frame rates are sufficient to show you, but this is very poorly motile. So let me just go back on that for one moment for you. And here you can see the difference between a normal cell and a cell from a patient with primary ciliary dyskinesia. And of course, because of the lack of movement of mucus, a whole series of respiratory anomalies exists within the chain of the respiratory epithelium from the auditory sinuses through to the bronchi. And of course, there are a number of genes that are involved in this. I've shown you a whole lot here. I don't want to talk about them in any great detail, but this DNAH5 and DNAH11 cause isomerism through sonic hedgehog gene expression. And I'm going to show you some patients, some animal examples of these abnormalities. We know, for example, that sometimes it can be expressed as an autosomal recessive, sex-linked recessive. Beg your pardon, SIC3 is one of the conditions where there is a ciliopathy as well as cardiac abnormalities. And the homobox transcription factor, PITX2, establishes left atrial identity. And of course, these are the chromosomes involved in describing the site of these abnormalities. Now, how do the atrial chambers become morphologically right as opposed to morphologically left? And they are, of course, under influence of laterality genes. I just described this PITX2 sonic hedgehog, which produces morphological leftness, and lefty and nodal, which stop this gene from reaching the right side, so that the right side develops under its own influence. And here are such examples. The senior author, Celia Lowe, is well known, and I was absolutely astounded when I saw these pictures, because as an imager, they provide us with a quite exquisite look at what's going on genetically. And so here we have a control animal with no manipulation. Here, the small left heart, a hyperplastic left heart. Here, the small right heart, hyperplastic right heart. Okay, here a transposition of the great arteries. Here, persistent trackless arteriosis, PTA, with a VSD above an AV valve. Perhaps this looks almost like it might be an AV canal defect as well. And double outlet right ventricle. And these are just some of the pictures of the scan with situs solitus. Here are the lobes of the lung. Here's the cardiac axis here. Here are the lobes of the liver and the stomach and the bowel. And of course, a mirror image relationship highlighted over here with the stomach on this side, the bowel in a reverse position, the lungs are inverted, and the heart axis is going the other way. And lastly, a heterotaxy animal that they managed to get, which has clearly got a stomach that's more midline than it is here, an abnormal liver, abnormal bowel, and a heart that they're not describing in this particular sequence as abnormal as well. And here are some of the primary ciliary dyskinesia mutations that I've shown you with the DNHC5 gene. And you see here tetralogy of Fallot, double outlet right ventricle. This is looking from the back forward, so this is left side and this is right side. And here are the two great arteries originating from the morphologically right ventricle. Here is a patient with an AV canal. I shouldn't say patient, an animal with an AV canal with bilateral superior vena cava draining into a common atrium with bilateral hepatic veins draining in here. A patient or an animal with left isomerism. And here another left isomeric picture showing double outlet from the right ventricle with superior inferior ventricles. And you can see the AV septal defect in this example as well. And here a little bit more magnified example of those two same features that you can see together with the histological slicing of this thing. And these are, of course, are sliced in a multiple slice technique like the scanning that we do with the fetuses. And we can go on more, showing double outlet right ventricle here. Beautiful example. The ventricular septal defect is bordered by the inner heart curvature and the crest of the septum. Both great vessels arise from the right ventricle, and this is a doubly committed, I beg your pardon, a subpulmonary ventricular septal defect. Here's an AV septal defect, and then examples of VSD and examples of right isomerism with classical trabeculations of the atrial appendages. So having begun to talk about isomerism, let's look at this concept that Gil Winofsky presented at one of our earlier meetings here on the subject, and I think is still available online. I hope that Grace and Sasha can comment on this later on, and I would certainly recommend that you read Gil's talk. But what I've tried to do is summarize the abnormalities that exist in this condition and the perspective that we as clinicians have to see in this whole spectrum of diseases. So first of all, the brain, small cerebellum, sometimes absent corpus callosum with abnormal synaptic connections and usual right-left brain functionality and handedness, which are variable. Then when we look at the bronchiole, they have a higher incidence of pulmonary infection and mucus production and bronchiectasis and obstructive lung disease. And of course, the abnormal bronchial arrangements, which we'll show you in a moment. Then, as far as the ear, nose, and throat, there's deafness because of the mastoidal sinusitis and middle ear infections that occur, micrognathia, choanal atresia, high arch parrot, laryngeal clefts, etc., and even deafness. When we look at the gastrointestinal tract, variable from position of the stomach, spleen, and pancreas, sometimes annular pancreas, sometimes absent gallbladder, sometimes extrahepatic biliary atresia, and definitely malrotation of the bowel, which I'll discuss a little later, and the Abernathy malformation of a portosystemic venous shunt. The kidneys, horseshoe kidneys, ectopic kidneys, duplicated ureter, single kidney, fused adrenals, and hypertension. And let's not forget the genital problems that occur in this condition. In the male, of course, the motile sperm are affected, and so there are about 10 or 12 genes on cilial motility that can be found expressed in this condition. So the sperm are immotile and do not fertilize, and the female often has a bilateral bicornate uterus, or even absent uterus can occur. So they present to the obstetrical gynecological community as problems with fertility and amenorrhea. They sometimes, with an absent uterus, have perfectly normally developed secondary sexual characteristics and have also amenorrhea. So that's the whole group. And of course, it requires the use of a huge number of different disciplines to manage these patients. And if you'd like to read a wonderful paper on this, I provided this case by Parapticho and Goldstein and Van Praag in the American Journal of Cardiology in 2000, which goes over all of these abnormalities. Well, I'm running out of time, so I don't want to talk too much about this syndrome, but we know that it has to be described from its veno-atrial position through to the atriums, the AV connections, and the great vessels, as well as the position of the heart in the chest, find out where the apex is, and all of these have to be described separately. So when we look at the whole syndrome, which I've called atrial arrangement options, we have the normal situation with the upper lobe bronchus here, short, early takeoff, the lobe here, trilobe right lung, bilobe left lung. Atrial appendages are depicted as a small little finger-like and large triangular appendage here, and the liver and stomach with the spleen. And of course, mirror image dextrocardia, or mirror imagery, or inversus, situs inversus, is merely a mirror image of all of these things. That's not too difficult to understand. In the two examples of heterotaxy, we have what I like to call double right-sidedness. 2 right bronchi, 2 right lungs, 2 right atrial appendages, a central liver, and no spleen is the usual case. And the left-sided with 2 long left bronchi, with 2 left lungs, 2 left atrial appendages, a more normal liver, but with multiple spleens. So that's the usual characteristic of isomerism. And when we look at the atrial morphology, which is still a fairly good way of looking at it, we have depicted here from the latest Anderson book, which you can see behind me, the pectinate muscles arising from this structure, the terminal crest, or the crista terminalis, as you might know it, and the left atrial appendage, which is a small finger-like projection here depicted with smaller pectinate muscles and often even absent pectinate muscles. And mirror imagery is just the opposite of that. A bilateral right isomerism would be 2 right atriums, and bilateral left isomerism would be 2 left atriums. Now, I'm using work of my colleagues that have been given this talk over years, and this is an example from Dr. Shi-Jun Yoon from Toronto, who described the overall heart through the patterns, the KV, the coronary sinus, the IVC interruption, juxtaposition of the aorta and the IVC, extracardiac total anomalous pulmonary venous return, and the presence of AV septal defects. And this can be used to recognize what you're doing. My feeling is that when you start seeing these things as a clinician without a table in front of you and without any expectation on the patient, each one of these little things brings up an example of where you may be dealing with. And once you can segregate left and right atrial isomerism along the lines, you have a much clearer pattern of whether you're dealing with left or right atrial isomerism. So overall, congenital heart disease in 100% of isomerisms, 80% in left. Bilateral KV are present in both, but in the right, there's no coronary sinus, as you can see, so it's direct connection to the atriums, and this is almost always to a left superior vena cava. So absent coronary sinus is a really good hallmark for right isomerism. Interruption of the IVC only occurs in 90% of patients. Between 80 and 90 is the standard of all the literature. So that means 20% of patients with left isomerism have a patent inferior vena cava, which again, from the work of Dr. Sanders and Gaver, show that there is a variability that occurs because of the multiple gene expressions that occur in this condition. Juxtaposition of the inferior vena cava and the aorta is very common in right isomerism, but uncommon in left isomerism. Extracardiac total anomalous pulmonary venous return, if you see this, always chase right isomerism. An AV septal defect in 90% and 55%. So, of course, this tells you you may be dealing with isomerism, but doesn't help you. Univentricular and biventricular atrioventricular connections with right isomerism are much more common. VA connection is concordant in only 5% of patients and 70% in left isomerism. Pulmonary atresia much more common in right isomerism, and left-sided obstructive disease much more common, and right-sided obstructive disease, not shown over here, more common in right isomerism. SVT occurs in right isomerism, and complete heart block and bradycardia occurs in the literature between 13 and 70% of patients. Now, intestinal malrotation in the severe or even benign variety occurs in almost all of these, so that doesn't help you. Partial thoracic stomach, much more common in right isomerism. Biliary atresia, more common in left isomerism, and I think you should always look for the gallbladder. Duodenal atresia is none or rare, but 7% in left isomerism. Urinary abnormalities, as we've shown you from the bicornate uterus, much more common in left isomerism. And overall, the abnormalities, extracardiac abnormalities, much more common in left isomerism. So if we want to look at this as the atrial anatomy, we have to use what they call the morphological method, which is to identify the structures on the basis of their most common part. And this was described by Dr. Van Praag many, many years ago. So here are two knockout mice. Here's the PITX2 gene, which causes left-sidedness, knocked out. And what you have in the fetal embryo, animal embryo, is bilateral right atrial appendages with terminal crests on both sides of the embryo. And if you knock out the lefty gene, your expression is left-sidedness. So you have what is classically a left atrial appendage bilaterally, together with an AV septal defect. So this is just an example of how genetics is telling us what kind of syndromes we are dealing with. And of course, we remember that the bowel rotates out from 6 weeks to return at 12 weeks in an orderly fashion. And this, of course, is destroyed because it's under genetic control. And here you can see the multiple spleens on both sides of the dorsal mesogastrium. Okay. And now if you look at the atrial appendage morphology, this is a right atrial appendage in situs solitus. And this is a right atrial appendage in situs inversus. So you can really recognize the right atrial appendage quite easily from its common constant feature, which is the junction of the appendage with the rest of the atrium. And you see the pectinate muscles both sides. And if you look here at the right atrium on the tricuspid valve, you'll see that the trabeculations come out of the appendage and surround the vestibule of the valve, whereas in the left atrial appendage, there's none of that. So clean and trabeculated. Now, in a study of Iomura on 182 hearts with heterotaxy, they looked to see whether the air outside of the appendages looked left side. They looked to see whether they were bilaterally or left or right, and whether they could not distinguish them with certainty. And on the basis of shape, they got right atrial appendages here and left atrial appendages here. When they looked at the junction, the uncertainty area, which is what we concern, diminishes. And when they looked at the pectinate muscle, they were able to characterize all of the structures. So here, let's look at some examples. Here's a patient who's clearly got symmetrical bronchi, atrial appendages. The pulmonary veins are draining to the right-sided atrium. There's the descending aorta. There's atresia of this AV valve, and there's an AV valve coming from this left atrium into the left ventricle. I'll take the labels away so that you can see that in real time as we saw it. We recognize this fetus and the features of abnormal pulmonary veins to the wrong atrium, a tricuspid atresia, and a univentricular atrioventricular connection put this in the isomerism category. So atrial appendage morphology is easy to see. Trabeculations, not so easy to see. I got this very interesting picture from Dr. C.R. Patel, courtesy of the Children's Hospital of Akron, Ohio. And Dr. Patel has been looking at the material in the bronchi of fetuses with breathing. And so he lowered the Nyquist limit and was able to see that this is, of course, the pulmonary artery here. There's 3-vessel view. There's the aorta, cava here on this side. And you see here the bilateral pulmonary arteries, but above them, you see with breathing, as the fetus inspires and expires, the cellular material reflecting off the fluid in the bronchi. And so you can see the relationship of the bronchi to the pulmonary arteries. And here's a patient who's got bilateral hypoarterial bronchi, epiarterial bronchi, I beg your pardon. The pulmonary arteries are below the bronchi. So you should be able to see that this is the case. Okay. And here we're looking at the hallmark of the atrial appendages with these terminal crests in a postnatal example. And here is a neonate that shows these terminal crests bilaterally. And here, just to highlight this again, is the fetal example of such. And we can see that after birth as well. Now, for the left side, here are two obvious left atrial appendages, little finger-like atrial appendages with the crenulation noted here. And here is an example of such over here, showing a AV septal defect with a little strand of tissue, the azygous vein lying behind the aorta, the pulmonary veins draining to this atrium, the atrial appendages, which are bilaterally left-sided, a complete AV septal defect over here, and even spongy myocardium. And if you want to go a little further, you can see that the atriums are beating at a faster rate than the ventricles because the patient actually has heart block. And this is such a patient who also has a spongy myocardium. And here is the cross-section of that patient who succumbed. And you see this classical appearance of atriums beating faster than ventricles, spongy myocardium. Here's the left ventricle with a dominant left AV septal defect, as you can see here. And I've oriented this so that it correlates with the specimen. Here's an example of the left atrial bilateral drainage of the atriums, one to one-sided atrium, one to the other side, again from C.R. Patel. And so you can see this very beautifully on the color flow as well. And of course, something that we're all aware of in 90% of patients, the azygous vein draining into the superior vena cava, shown by a CT scan. And here, examples in the abdomen of the azygous vein lying behind the aorta, depends on how you look at it, and eventually tracing it back into the atrium with and without color flow information. So how about the spleen? Well, the spleen is good, but it ain't great, because here green shows with isomeric right atrial appendages and left atrial appendages that only 64 and 55% conformed, that in some there was an absent spleen with left atrial appendages, and in some had a solitary spleen, as we've shown, and then of course there were ones that we couldn't recognize. And in right atrial appendage, 14% of patients who weren't supposed to have a spleen had a spleen, and 4% had multiple spleens. So this violates the law of making the isomerism the thing. Now, I'd like to just finish, if I may, with this condition, because these are harmonious patterns shown in the limb paper that I mentioned earlier on. Bilateral right atrial appendages, bilateral bronchi, and here is no spleen. Here are the terminal crests that can be recognized. Here's a patient with bilateral bronchi, but also with bilateral bronchus suis or pig bronchuses, okay? And also, again, no central stomach, no spleen. Left atrial appendages, here with the bronchi being underneath the pulmonary arteries, hypoarterial bronchi, and with multiple spleens. And again, on that side as well. So there's the paper. Now, when we look at disharmonious patterns in their survey, here are right and left atrial appendages, but with bilateral right bronchuses and multiple spleens. And this occurred, and this is the important issue here, this occurred in 20% of their patients. So 1 in 5 patients that they had with isomerism violated the laws because of variability of organ findings. Here again, you see multiple spleens with different type of atrial appendages, and again, bilateral bronchi. As far as the left is concerned, here is, I beg your pardon, a patient with bilateral right atriums, but with left-sided bronchi and with a spleen. And here, a patient with 2 left atrial appendages, but with right-sided bronchi and no spleen. So these violations did occur, and it occurs in about 20% of patients. So we have to look for this as an expectation in isomerism, and we have to understand that not all of the patterns fill that example. And why is it important? It's important because the survival of these patients that we have to counsel is also completely different. So if patients have normal anatomy, they have a reasonable but still somewhat attenuated survival curve. Biventricular have worse if they have biventricular repair for their diseases. And the single ventricles in left isomerism have about 30% at 20 years of age. In right isomerism, they almost always univentricular. They almost always need surgery, and their classification is a more severe, excuse me, a difficult classification than occurs in right isomerism. And their survival curves at 25 years are down into just over 20%. So I'll leave it at that. And that's the reason why it's important, because we have to counsel these patients. So in conclusion, the syndrome currently described as heterotaxy exists and is of considerable significance and should be classified into its right and left isomeric subsets. Thank you very much for your attention. And if there are questions, I will be able to answer them later.
Rima, you're muted here.
I'm not talking.
Okay, I'm talking. Thank you very much. Very, very important talk. And I think we can answer 1 or 2 questions now, and then at the end we can have more time. So let's look at the panel and see here. Is conotruncal abnormalities an association with isomerism? From Dr. Singh?
Yes.
Okay.
Yes, I'm a double outlet right ventricle. I've showed you even the examples in the animals. Well, I decided to choose these animal pictures because they were so good. But I think that's true, that we see these examples all the time. So every time you see a conotruncal abnormality, particularly double outlet right ventricle, I think, or transposition, you have to think, when not just simple transposition, but complex transpositions with lots of abnormalities. You have to think, is this isomeric? And I mean, I think you can start doing this in the fetus, which is the point of this discussion.
Now, going back to the same question, let's link this to genetics, because most of your talk at the beginning was with genetics. So if I have a conotruncal abnormalities with isomerism, do I expect it to be a 22q or not in the box of 22q?
I can't hear you so clearly. Is this Dr. Prince Chinwezi's thing? In right isomerism, is there presence of total anomalous pulmonary venous return? The answer is yes. If you go back and look at the talk again, which you can see on YouTube, at the YouTube thing, and I hope that for those of you that don't know this, Dr. Van Leuven will again put up the website address so that you can really look at this talk again. But yes, isomerism is particularly the extracardiac types, supracardiac and infracardiac types of total anomalous pulmonary venous return are a common occurrence in right isomerism. In left isomerism, the veins are either normal, the total anomalous pulmonary venous return is unusual, and the other pattern, as I showed from one of the slides from Akron Children's Hospital, is that they may have bilateral isomeric venous drainage. One group to the left-sided atrium and the other to the right-sided atrium.
But having this total anomalous is not a must to have it when you have right isomerism or left isomerism, going back to the same point, it's not a must to have abnormal venous drainage, pulmonary venous drainage. Is it a must to be part of isomerism?
Well, yes and no. But I mean, I think that if you look at the series, you'll find that a number of patients, fetal patients, where they describe isomerism, the patient, anomalous pulmonary venous return, there is also a substantial amount of those patients that actually have isomerism.
You can have isomerism with normal pulmonary venous return. Is this correct?
I'm sorry, repeat that for me.
Can you have isomerism with a normal pulmonary venous return?
The answer is yes. With right isomerism, let's not talk about left, because you have to sort of separate these out. Left isomerism frequently has normal pulmonary venous drainage. Okay.
Right.
But right isomerism can have a normal venous drainage, but frequently, as Dr. C.J. New showed, 50% of them or more have a totally anomalous pulmonary venous return. And the group from Toronto described patients with this abnormality that required surgery in the first month of life at 5 years of age. This is McCrindle's data, had 0 survival. So I think that it's important to understand that the presence of venous drainage in right isomerism really knocks the prognosis for survival down.
Thank you very much. Grace, can you go to the next speaker?
Yes, please.
Thank you.
Thank you very much, Dr. Suleiman. Please don't leave us, because at the end there will be lots of questions. Please allow me to introduce our next speaker, Dr. Anita Mongredi. And Dr. Anita Mongredi is the director of the Fetal Cardiovascular Program at UCSF. She has lots of awards, especially in education and research. I've known her for years, and today she's going to talk to us about a very important topic about fetal intervention and the Registry of Fetal Intervention. Thank you, Anita. Please go ahead.
Thank you, Rima, for the kind introduction. It has been now several years since we first met, hasn't it? Maybe decades. Well, it's a pleasure to be asked to speak to this group today and to speak on a topic that it's very near and dear to me, the International Fetal Cardiac Intervention Registry, and you'll see why in a moment. I have no financial disclosures or other interests to discuss. I will start out talking about the current status of fetal cardiac intervention in the context of overall outcomes, not a lot of detail. And then I'll talk about some of the current applications and published data and introduce innovations in fetal therapy as well, all while I'm discussing the registry concept and where we are, where we started, and where we've come to, and then answer any remaining questions during the question and answer period. We'll start off talking about fetal intervention for aortic stenosis. This is probably not a new concept to anyone in this audience, that we can see in mid-gestation poor left ventricular function, dilation in the presence of aortic obstruction. And as was shown years ago by the group in Boston, Karin Macaleo and Wayne Turetsky, looked at a group of patients who presented with this finding in early gestation and showed that in the presence of left to right flow at the atrial septum and retrograde flow in the aortic arch, that in their hands, 100% of these patients progressed to hypoplastic left heart syndrome. And since this aortic stenosis picture in mid-gestation looks so similar to postnatal aortic stenosis, the idea of being able to use a balloon catheter to open up the aortic valve might reverse this process and allow the patient to have a normal sized left ventricle. And so with that idea, the balloon procedure was adopted despite early failures, which I won't talk about. I will talk about the approach in Boston and Linz and another effort by the AEPC as a sort of counter argument to this idea, and some issues with defining the natural history. So fetal aortic valvuloplasty, what is it? Well, it's actually a fairly simple procedure. Percutaneous access, a needle is introduced through the maternal abdomen and in a perventricular approach. And then that same needle is used as a way to introduce the balloon catheter through the needle and across the aortic valve. Have a picture. This is one of our patients. Fairly simple in concept, and for our obstetric and radiology colleagues who are used to putting needles into fetuses for a variety of reasons, fairly simple for them to accomplish within a few minutes once the fetal position is good. The needle is shown here, introduced through the aortic valve, and then the balloon is blown up. And these are common off-the-shelf balloon catheters used for percutaneous coronary intervention in adults. And this is a different patient of ours at UCSF, and a so-called successful intervention showing the proof of concept, at least, that at 9 months of age, the left ventricle is not hypoplastic. The baby did not evolve to HLHS, but I should say that there is evidence here of a prior hybrid procedure followed by a Ross-Kono procedure and stripping of endocardial fibroelastosis. And this patient actually spent the first 9 months in the hospital. And so the quote unquote success is relative in some of these patients. Now, some of the patients, like this one, which is the one that was shown in the first pictures, have residual aortic stenosis, but can get out of the hospital with only an aortic valvuloplasty and reasonable circulation. Unfortunately, the natural history of severe neonatal aortic stenosis is not perfect either. And this patient succumbed at about 3 months of age, had a sudden witnessed collapse, and was unresuscitatable, and at autopsy had severe hypertrophy, EFE, and a dramatically abnormal still aortic valve. And another patient, this one survived. This is the explant at the time of infant transplant, showing how severe the disease remains even in what we would call a successful intervention, who's discharged in the neonatal period as a biventricular outcome. So what do we know about the data? The centers in Boston and Linz have been out this now for almost 20 years, and I don't have time to go through all of their data. They've published it at certain intervals. I do want to focus on one of the more recent papers from Boston, the first 100 patients. And in this paper, Lindsay Freud reported 38 out of the first 100 were biventricular at the time of the writing. 31 of those had been biventricular from birth, and they had about a 10%, 11% loss rate. Following these patients out up to 10 years after birth, the curves diverge. Patients who were biventricular versus hypoplastic left heart syndrome, and sort of come together at 8 to 10 years. But if we only look at the patients who were biventricular from birth, that is, some of these were Fontan conversions or single ventricle conversions, so clearly borderline patients as far as being biventricular, but the ones that were biventricular from birth were all still alive. The group in Linz has fewer patients, but getting to be a similar experience, and published now almost 10 years ago, their first 24 patients, in which 2/3 of the outcomes were considered biventricular, and even left heart obstruction with high drops had responded favorably. They reported their complication rates, which were similar to the Boston group. About 50% of the patients do have some sort of complication, but fetal death immediately due to the procedure, relatively rare at about 10%. Newer Boston data was recently published by Kevin Friedman, And this is a testament to alterations in their approach and continuing learning experience with the actual procedure. So as they have learned more about which patients are unlikely to respond and have stopped offering the procedure to those, concentrating on the ones that were most likely to have a favorable outcome, they have gotten their biventricular rate up over 50%. And the patients who do best with the procedure were analyzed. This is a CART analysis looking at that patient population. And basically the older patients and the patients who had higher left ventricular pressure at the time of procedure were more likely to be biventricular at birth. So that all seems pretty compelling, but I just wanted to put out there that there is an alternate school of thought that is challenging not the procedure nor the outcomes necessarily, but the case selection and the idea that this poor left ventricular function in mid-gestation always progresses to hypoplastic left heart syndrome. And so this is a paper, a multi-center effort looking at the natural history of mid-gestation aortic stenosis from the AEPC. They had over 100 fetuses who did not have any cardiac intervention, and they retrospectively applied those so-called Boston criteria to identify candidates. They then looked at survival and postnatal circulation in the patients that would have been candidates versus not. And of 40 who met the above criteria, 33% were able to have a biventricular repair. Now that's without having had an intervention. They then, of course, did have some patients who had intervention. And so in a second paper from the same data set, looked at 59 successful interventions, of whom 47 were live born, and followed them out up to 10 years. They found that the fetal cardiac intervention, that's FV, this top line here, did confer a survival advantage in their patients. But when they looked at what the actual outcome was in terms of circulation, the patients who had fetal valvuloplasty and were univentricular at birth were the ones that were driving this survival advantage. So just a curious, thought-provoking idea that the valvuloplasty seemed to have done something even in patients who were ultimately not biventricular. What about the rest of the world? This is now getting to be a little bit older data, but illustrates a point that in Argentina, for instance, the technical success is not so hard to achieve, but in their postnatal outcomes, although some of the patients survived, most of the patients survived to birth, none of them survived beyond the neonatal period. And in looking closer at this group, it is largely because the postnatal management and postnatal availability, say, of univentricular palliation in some regions of the world is not the same, and the outcomes can be much worse. And so it's not about just the procedure, it's also about the candidates that we choose and about the postnatal care. We don't know a lot about longer term outcomes. There has been a high rate of reintervention in the neonatal and infancy period for these patients, and a high prevalence of pulmonary vasodilator use in that Boston group. So certainly not a cure for hypoplastic left heart syndrome, but leaving the patient with aortic stenosis and sequelae of that in the long term. And neurodevelopmental outcomes have not really been studied in more than one cohort. And so in terms of aortic stenosis, fetal intervention, I think it is clear that we can change the natural history of the disease, but it is not clear to what end. This is not a simple procedure that will fix the problem in utero. It is the beginning of a treatment algorithm that includes postnatal care and additional procedures after birth. I present that to show that there are a lot of single-center data and some biases out there. And in 2009, I was part of a working group looking at other centers that had procedures done and had not yet published their results. And it turned out there were quite a few other than Boston and Linz. And so we together decided to start this fetal cardiac intervention registry and have now over a decade of data sharing and collaboration that I want to go through with you. These are the centers. We have now, I think, 40 centers in 18 different countries, with 27 of them actively entering data. Some of them are the AEPC working group, who were at the time that we started the registry part of the other study that I presented. And so they haven't been entering patients, but they've been very active in analyzing data and the other ideas behind it. These are our countries and just some of the investigators. This is really a huge effort, and I have to thank everyone who has been involved. The registry collects voluntarily submitted de-identified diagnostic and procedure-related data. Each of the countries abides by their own IRB or ethics board regulatory protocols. All of them sign data use agreements, in this case with the University of California, San Francisco, where the data registry is housed. We ask for maternal fetal dyads referred from 2001 onward for possible fetal cardiac intervention to our fetal therapy sites. And we collect limited outcomes after neonatal discharge, but most of the granular data is about the mother, about the procedure, and about the neonatal, immediate neonatal outcome and pregnancy outcome. There are about 250 data fields. This is a REDCap web-based database that is very easy to use and easy to add fields to. Lots and lots of those. And what are the data that we have? As of July 2020, the last time I updated this, we had 791 entries. There are now almost 820. 488 of those were actual interventions, and the others were patients who did not end up having an intervention. Most of them are aortic valvuloplasties, but a fair number of pulmonary valvuloplasties and atrial septal procedures. A few newer procedures that I won't talk about. The gestational age at intervention, as one might expect, is in the late second trimester, so an average of, a mean of 26 weeks, the median also of 26 weeks. All of the procedures after 2013 have been done percutaneously. We collect details of maternal and fetal anesthesia. There are no maternal deaths or major complications recorded, and overall fetal-related losses are about 11%, so in keeping with the Boston and Linz data, which are censored from this data set. Preterm delivery occurred in 70 of the patients, about 24%, which is also sort of what we would expect with congenital heart disease. So probably in most cases not due to the procedure. And among the live-born infants, there has been noted to be a favorable result in 67% of patients. Complications are not unusual, similar to the Linz data on their 24 patients. This is now several hundred patients, and we're seeing the same pattern: bradycardia and pericardial effusions that require treatment in about half of the patients, but death being very rare. And the pregnancy outcomes, as I just said, mostly term birth, with a term versus preterm about 1 month, what one might expect without any intervention. And although the average time of birth is 38 weeks, you can see that it really clusters near that term mark. So that's the overall registry. I'm not going to go into a lot of detail about the aortic stenosis patients because we found that's very similar to the single center reports. But we could use this registry for other indications. I mentioned atrial septal restriction, and here in patients with left heart hypoplasia, with left atrial hypertension and intact or severely restrictive atrial septum, it is also possible to approach this percutaneously. Important to note that the goal is different for atrial septoplasty or stent placement, in that we're just trying to get a more stable neonate and improve immediate survival with this atrial decompression, with potentially improving pulmonary outcomes. But this is a much more technically difficult procedure. You can see this is a 22-week fetal heart with hypoplastic left heart syndrome, very tiny, and the Boston group, Brian Kalish, published in 5 of 9 attempted stents placed, only 4 babies survived, and many of them had problems with stent dislodgement or other complications. Nevertheless, other groups have also been able to publish some success with this procedure. And this is just a demonstration, a patient that had the stent placed in Boston, the immediate change in pulmonary vein Dopplers from this to and fro high pressure, high left atrial pressure, to a normal left atrial pressure and normal pulmonary vein flow. So this does seem to be something that might improve outcomes. And so we looked at what we had in the registry in 2007. David Jansen, who at the time was a fellow in Michigan, put this paper together, where we had 46 total fetal cardiac intervention patients from 8 different centers. And although the outcome of survival to discharge was not different in patients with septoplasty or stent versus no intervention, so no intervention, no difference in overall mortality, we did find a high incidence of procedural successes. And also, interestingly, since this is a larger group, we're able to analyze and see that the stent was more likely than septoplasty alone to result in a clinical success at delivery, that is, a stable neonate. Fetal complications were more frequent than with aortic valvuloplasty, but not often fatal. And if there was a procedural success, the neonates were more stable and had a trend towards better 30-day survival. We also, though, looked at the maternal outcomes and immediate post-delivery outcomes. And I think, though this was statistically significant, it's also quite clinically significant that if you can imagine now, hypoplasts with a restrictive or intact atrial septum, if they had a successful procedure, it's shown here in blue, only 30% of them needed resuscitation, and fewer than 60% of them even needed preoperative intubation and ventilation. So definitely a success in terms of the immediate postnatal outcome. I'm going to skip that to go to the longer term outcomes, which were a little bit more disappointing, although there does seem to be a difference in patients who had a cardiac intervention done and the atrial septum or stent still open at birth. Looks like about a 60% survival at 3 years, and only 20% survival in the patients who had nothing done or had the stent occluded at the time of birth. This wasn't statistically significant because of small numbers, but did seem to be somewhat promising. The problem, I think, is that they continue to die even outside of the neonatal period, and that is probably due to this pulmonary lymphangiectasia that develops in the presence of left atrial hypertension in utero, as shown in this fetal MRI, so-called nutmeg lung. And it is really unclear at this point whether atrial septal stenting or atrial septal interventions in the fetus actually reverse this process, and if it does, to what extent. So there's still a lot more work to be done there, but interesting information that we can get from the registry. There's also registry data about right ventricular outflow tract obstruction. This is a paper that we recently, just in 2020, was published in Fetal Diagnosis and Therapy. Whitney Hogan was the first author. She's in Utah, where we evaluated the 73 unique patients that were entered in the registry, and almost 50 of them had fetal cardiac intervention. About half of them had pulmonary stenosis and half had pulmonary atresia that were in the fetal cardiac intervention group, which illustrates a problem with this particular procedure and this data set, that the criteria for the mid-gestation right ventricular outflow tract obstruction patients who will be biventricular at birth versus needing to go down a single ventricle palliation pathway are a lot more gray than the HLHS patients. And even outcome is a little bit more difficult in these patients, whether or not biventricular versus a 1.5 ventricle outcome, which of those to choose as your outcome is a little bit gray. And as we all probably know, postnatal approach to the PAIVS patient varies widely depending on institutional preference. Nevertheless, we at least can get some information on the procedure-related outcomes in these patients. And we found that the procedure-related loss rates seem to be a little bit higher, and that may just be due to the relative rarity of the procedure. The biventricular outcome at birth was fairly high, but one of the problems with this is that a lot of the patients had moderate to severe tricuspid regurgitation, and with the presence of antegrade flow and or moderate to severe regurgitation, my own bias is that most of those patients would have been biventricular anyway without a fetal procedure. What wouldn't have happened, though, is something interesting that we found in the more granular data, and that is that the tricuspid valve grew at a faster rate in this yellow line is the patients who had a successful fetal cardiac intervention. So it does seem that the growth of the tricuspid valve is faster in patients who've had a procedure. And this is not, since we didn't have a real control group, I just show fairly robust data from the Children's Hospital of Philadelphia following patients longitudinally with RV outflow tract obstruction, and showing that we really don't expect the tricuspid valve to grow. There's no change in Z-score, even went down in the patients who started out with a somewhat small Z-score. So this is expected natural history, and what we observed was tricuspid valve growth. And so something somewhat promising, but very problematic in that the selection criteria seem to be all over the place with the pulmonary valvuloplasties. We have, as I said, the ability to look in quite a bit of detail at the actual procedures. And Neil Patel and Jay Pruitts from Los Angeles recently published this data on the actual procedural variables in patients who had at least one cardiac puncture. And the interesting thing about this data set was that the needle gauge correlated to procedure-related complications, and specifically pericardial effusion, which I've already mentioned doesn't correlate with death, but the number of punctures with the needle seemed to be more associated with death. So the take home from this is that the needle gauge does seem to matter, and a smaller needle seems to be better, and that a single cardiac puncture is really should be the goal of this procedure. And so fetal positioning and team experience seem to be important. And along those lines, what is the correlation between procedure experience and outcome? A paper that's in preparation now from Shane Morris in Texas and Monique Huck, looking at the centers who have done more than 3 procedures. So this narrows it down to 11, with over 100 total procedures, and they looked at the technical success and the fetal peri-procedural and long-term or pregnancy outcomes, and found associations with both fetal size and gestational age. This is, though, the important slide. The team is a very important aspect of this procedure, as well as the other things that I've already mentioned, with center volume not so much mattering with technical success and complications. I think we might expect this from large fetal centers who perform other types of fetal intervention procedures, but the fetal death rate really did seem to improve once the procedure volume is over about a dozen procedures. So the effect of center volume on survival of the fetus does seem to have a learning curve. There are other possibilities for this registry in the future. In utero pacing is something that has had a few case reports and no survivors, but the group in Los Angeles has recently come up with a very innovative approach, a very tiny battery and a wireless device that is small enough to be inserted through a 3.3 millimeter cannula and can be directly sort of screwed into the apex of the ventricle. And they're currently posting a clinical trial for this pacemaker in patients with SSA or SSB induced heart block. I'll finish with a little bit about the mother. This whole talk has been about the fetus, really, but we can get information about the mothers, and we should have this in order to counsel them. Maternal outcomes for fetal surgery in general have been noted to be mostly positive. Most maternal complications are in actual hysterotomy patients, and all of our fetal cardiac interventions are now done percutaneously. So death is pretty much unheard of. Chorioamnionic separation and preterm labor and PPROM can be expected in 12 to 25% of percutaneous procedures in general, but seems to be a little bit lower in the fetal cardiac intervention patients, as was reviewed by Christoph Walmuth several years ago. There were no maternal deaths and no major complications in terms of the maternal outcome, transfusions, infection, et cetera. But again, this 10% pregnancy loss rate comes up as a consistent number. And so what we usually counsel for fetal cardiac intervention is about a 10% pregnancy loss rate, usually right around the time of the procedure, if not directly during the procedure, with very few maternal complications and almost never bleeding necessitating transfusion. But from our registry, we've also shown, this is the same data that I showed earlier on the atrial septal intervention patients, that there can be a hidden maternal benefit if there's a physiologic success to the procedure. And that is that in our registry, far fewer of the mothers needed a cesarean section. There was no, the cesarean birth was not necessary if the atrial septal stent stayed patent. And so if we can decrease the need for maternal operative deliveries and C-sections, that is an indirect benefit to the mother. And so to summarize the current state of this cardiac intervention registry, which has been now over 10 years, and as I said, 800 patients and almost as many investigators. The procedures, fetal procedures, are probably now clinical care for select patients with aortic stenosis, evolving hypoplastic left heart syndrome, and restrictive atrial septum. Not so clear that there's a benefit for PA-IVS. There is evidence of salvage without great evidence for other diseases like mitral valve dysplasia sequence and HLHS with restrictive septum and pulmonary lymphangiectasia. There are research protocols coming up of fetal pacemakers and also other non-interventional medical interventions. And fetal therapy is becoming an organized clinical presence with, though it's mostly still unfunded and highly reliant on registry data, some real good experience out there. But the volume of the center does seem to matter. Case selection matters quite a bit. There are over a dozen centers with enough experience to have reasonably similar procedural outcomes, but we need to continue to investigate and continue to share data in order to advance the field. There is evidence that we're able to change the natural history of congenital heart disease with these therapies, but whether that is going to be a long-term advantage to these patients or not is going to require us to continue to work together. I want to thank Dick Upkis, Wayne Turetsky, Helena Gardner, Abe Rudolph for their mentorship and help with this project, and Katie Archbold, who was absolutely amazing at keeping us organized.
Thank you very much, Anita. A beautiful presentation and beautiful summary. And I have a few questions, but let's open the floor for discussion from our team. Let's see. It's spectacular. This is from Dr. Arapa. It's spectacular to carry out this type of intervention in the fetal stage, but how should we assess the risk, the benefit, and the ethical part in a center that initiates these procedures?
Mm-hmm. Thank you for the question. I think that there's a lot of additional data that I didn't have time to present, and some papers from both the International Fetal Medicine and Surgical Society and the North American Fetal Therapy Network sort of position statements on what it takes to be a fetal center, and part of that includes constant review, data sharing, and involvement of an ethics team. Definitely, it was a significant question early on when the Boston group was doing the procedures under general anesthesia, and maternal risk was potentially much higher. I think the maternal risk has been shown over and over again, and mostly from the registry, to be very low. But definitely the ethicists play a part in our team at UCSF, and in these statements from large fetal therapy organizations, it's considered a necessity to have the input of ethics.
Thank you. We don't have any more questions from the panel, but I have a question for you, or two questions. Beautiful data. Why is there a difference between right and left heart intervention? Is it the incidence of the disease, or the procedure, the technical problem? It means data selection. Why is there a big difference between right and left heart?
I think it's probably just technical. Having talked to people about these, I don't do the pulmonary valvuloplasties at UCSF. We only do the aortic, or we've only done the aortic valvuloplasties. The dilated left ventricle is a pretty easy target, and it's fairly simple to get the alignment appropriate. The right ventricle, what we're targeting is patients who have already some degree of right ventricular hypoplasia, because as you know, the right ventricle doesn't usually dilate in the presence of severe obstruction. It just stops growing. And so the ventricle is not a large target, and you really have to get the needle into the infundibulum. And so the fetus has to be in a perfect position.
I was told that the angle is a bit difficult. But I think the people from Linz, I don't know if they published, but they have a big series of right ventricular intervention. Is this correct? I'm not sure the data that is included or not. And my last question to you is that this is beautiful stem cell. What is coming in utero? What are we planning to do with that?
I had to take out some of the slides that I had on stem cell therapy, but thank you for asking. We have at UCSF, we have a few clinical trials looking at in utero stem cell therapy for thalassemia, and are starting up a protocol for storage disorders. And what we have seen is that we can induce immune tolerance for these patients. So I think that it's something cardiologists to keep their eye on, even though treating thalassemia may not seem like something we're interested in. The idea of inducing immune tolerance in the fetus is intriguing and certainly something that would interest us as we look to heart transplant as a viable option for some of these single ventricle patients. So that's where that is at the present.
And just a personal question. I mean, people tend to say, okay, some are with, some are against intervention. If you had a patient, I mean, would you send them for intervention? Because what you showed is that it depends on when you catch them, on the anatomy, on the gestation, on the outcome, on the procedure, the natural history, the surgeon, blah, blah, blah. So people would like to know, oh, should we have a center for fetal valvuloplasty? Or some would say, no, it's not very promising. What would you say?
I think that the valvuloplasty is now a pretty simple thing to do and fairly low risk. And in a experience center, it makes sense to send the patients to the experience center for the valvuloplasty and see what happens. The postnatal management of the patient has to be done also in an experience center, but there are a lot more of those. And so I don't think that they all need to have all of their care transferred, but I also don't think that just because you do postnatal care that you should start up a fetal cardiac intervention center. There's just no reason for it. There are enough centers. These are still very rare patients. And I think our volume to outcomes data, when this paper is written and comes out, will really discourage people from just a one-off seeing it. Now, would I send a patient if I didn't work in a center? Yes, I would. The criteria as outlined by the Friedman paper are really, I can give a patient who's 26 weeks with high pressure left ventricle, I can give them a pretty good 75% chance that their baby is going to have a biventricular outcome after birth. I usually tell them that it's going to be with a neonatal Roscono procedure, but still, my bias is that a neonatal Roscono procedure is better in the long term than single ventricle palliation. So, but it depends. I tell patients we're not curing the disease, we're giving your baby more options in the postnatal period, and the options may still favor single ventricle palliation in the end, or they may favor the treatment for aortic stenosis, but your baby still has heart disease. And I think that that's important to get across to patients. But to come back to your question, yes, I would. For aortic valvuloplasty, I have over the years changed my position on this and I'm now pretty convinced.
But you would choose your patient carefully, right? This is the message. Yes. Not every patient. You have to really know which patient and what gestation, and just not because it's happening. We have to choose our patients for a lot of factors, the center, the good results, and the outcome. Thank you very, very much, Anita. I really learned a lot today, and I'm sure the audience, you have a big audience with us. Our next speaker, allow me to introduce Ulrike Herberg. Dr. Herberg is the Director of Fetal Program at Bonn University at Friedrich Wilhelm University in Germany. And I know Ulrike a long time ago, since we were assistant doctors together in the same hospital and with the same mentors. Anita, Ulrike is going to talk about an important topic is the cardiomyopathy, fetal cardiomyopathy. Please go ahead. Welcome, Dr. Herberg.
So thank you very much, dear Rima. Thank you for a kind invitation to this exciting webinar as well. It is a pleasure to speak to this group today. So hopefully you are able to see my presentation, yes?
Yes.
Okay. So fetal cardiomyopathy is a rare disease, and it is found in about 2.5% of fetal heart disease. Fetuses will either present by chance during routine screening with a dilated or hypertrophic heart, or in heart failure, mostly at the median gestation age, about 22 to 24 weeks. Similar to postnatal cardiomyopathy, the etiology of fetal cardiomyopathy is multifactorial and often not known, and therefore a more descriptive classification is used. Most of the cases are of dilated forms, and some are hypertrophic cardiomyopathy, about 1/3 of the cases, and restrictive forms are very, very, very rare. So in this case, it's a restrictive form with biatrial dilatation and small right and left ventricle. It is important to classify primary myocardial disease versus secondary myocardial dysfunction. Myocardial dysfunction can be found secondary to congenital heart disease. So this may be severe valve insufficiency, tachycardia or bradycardia-induced cardiomyopathy, or channelopathies, volume and pressure load, like the findings in recipients with TTTS, extracardiac shunts, high output status, or fistulas, anemia, renal disease, and it's quite important, in addition, the most frequent cause of excessive myocardial hypertrophy may be due to maternal diabetes and diabetic fetopathia. Today we want to focus on primary myocardial disease. The causes of cardiomyopathy in the fetus are diverse. In cases where there is a familial history of metabolic or muscle disease, prenatal genetic testing may be available depending on the condition. But most often, if there's no familial history, metabolic disease may not be identified prenatally. Genetic disorders and chromosomal anomalies, as well as Noonan syndrome, should be taken in account. Extrinsic causes like infections, CMV, Coxsackie-B, parvo, and adenovirus are the causes for myocarditis, and after myocarditis, sometimes secondary cardiomyopathy is developing. We also have to mention immune-mediated diseases like lupus and other diseases with autoantibodies and immune-mediated myocarditis in the fetus. This is my first case I want to share with you. It's a primary myocardial disease with late presentation in 35+ weeks with an uneventful family history. This fetus presented with hypertrophic biventricular cardiomyopathy with a thickness of the interventricular septum of about 8 millimeters and pericardial and pleural effusion. There was no tricuspid regurgitation, no mitral regurgitation, no left ventricular outflow tract obstruction, normal inflow in both ventricles. The venous duct flow was not really pathologic, with maybe a minimal negative A wave, and the CTA was about 0.5. So what is the diagnosis? And do you think what is the prognosis for this fetus in late pregnancy? Okay, it's a biventricular disease, but we don't have really very severe diastolic dysfunction. Let's go on. So this child was born, and now we are able to see the first echocardiography after birth with a biventricular hypertrophy, very large septum, and maybe also kind of non-compaction. But the neonate developed severe left heart acidosis, had a cataract, had respiratory insufficiency due to myopathy, and had to be intubated after 2 days. And all genetic tests, panels, muscle biopsies, metabolic screening, MRI, family history were negative. So there could be mitochondriopathy, but this was not proven. So in this case, we had idiopathic hypertrophic cardiomyopathy, and this child died after 8 weeks intensive care therapy. This is another case with Noonan's syndrome, seen in the 28 weeks of gestation with growth retardation, polyhydramnion, and thoracic hypoplasia, and presenting with hypertrophy of the left ventricle. I'm sorry I don't have a movie. This child did survive and is still alive and is doing well, has a biventricular hypertrophic obstructive cardiomyopathy, but doing well. Another case of Noonan syndrome, presenting very early at 17th plus gestation with a hydrothorax, and the genetic diagnosis was done in 18 plus weeks, assuming a Leopard disease. And here you are able to see the drainage of the hydrothorax. So if we think about hypertrophic cardiomyopathy, we have to think about genetic syndromes, but familiary hypertrophic cardiomyopathy is really rare. Chromosomal abnormalities and Noonan syndrome, metabolic disease. But, and this is very important, we have to exclude extracardial disease, fetal renal disease, ductal obstruction, and which is more important, maternal diabetes. So this is a fetus with maternal diabetes in the 20 plus week, and this is the same fetus in 34 plus weeks of gestation. And it's very important that such hypertrophy tends to occur late in pregnancy, typically beyond 13 weeks of gestation. The next cases are dilatative cardiomyopathies, and you have seen the first four-chamber view of this fetus with the RV non-compaction and mostly involving the right ventricle with right ventricular and right atrial dilatation, and the left ventricle was compressed. In color Doppler, we do see moderate tricuspid regurgitation in this fetus and also mitral pulmonary regurgitation with a decent antegrade flow across the pulmonary valve. So what is the diagnosis? We think it's right ventricular non-compaction. And what is the prognosis in this case with a predominantly right ventricular cardiomyopathy? Let's go on. So in postnatal follow-up, this is the four-chamber view, and there's still the right ventricle is having a low contractility. The left ventricle is filling well, and this is the M mode. Right ventricle is large, low contractility, left ventricle is okay. 6 months later, we do see a four-chamber view, which seems to be nearly normal. So there is a really good contractile left and right ventricle in normal M mode. And here in isolated right ventricular non-compaction, there's quite a good prognosis. But this may be different in the following case. Oh, no, I will show the following case just in a minute. So what is non-compaction cardiomyopathy? I think you may all know this. This is abnormal excessive trabeculation. Here, this is a normal right ventricle, and this is a right ventricle with non-compaction. Clinically, this results in heart failure, arrhythmias, thrombi, endocardial fibrosis, and can be isolated or associated with congenital heart disease. Now, this is another patient with biventricular non-compaction. With Barth syndrome in the previous child, this is an X-linked cardiomyopathy. And this fetus is again presenting in later gestation. And on the left side, there's a color Doppler, shows a moderate contractility and tricuspid regurgitation. On the right side, pleural effusion and ascites, but still decent contractility. So what is the diagnosis? Biventricular cardiomyopathy with tricuspid regurgitation and already pericardial effusion. And what is the prognosis? How can we follow fetuses with fetal cardiomyopathy And is there any scoring system like New York Heart Association or Ross score for fetuses which may predict the severity of the condition? So we have to look for instruments to assess the systolic function, the diastolic function, and also maybe extracardiac assessment of diastolic function. In heart failure, end diastolic pressure is increased. So the right ventricular end diastolic pressure is increased and is followed by an increase of the venous right atrial pressure and the venous pressure in the liver, the vena cava inferior, the liver, as well as in the whole venous system of the fetus. Changes in the Doppler flow pattern are first seen, therefore, in the vena cava inferior or venous duct. So if the right atrial pressure, right end diastolic pressure is increased, the right atrial pressure is increased, then also the duct may be shown differences in its flow pattern. This is the normal flow across the venous duct. And this is the flow in a venous duct with increased right atrial pressure. And we do see the negative A wave. More severe derangements in systemic venous pressures are reflected in changes within the umbilical vein. And this is the normal Doppler of the umbilical vein. And these are umbilical vein pulsations, which show severe cardiac impairment. So in our case with biventricular cardiomyopathy, the venous duct has a negative A wave and the umbilical artery flow is normal, but the umbilical venous flow seems to have mild pulsations. The cardiovascular profile score published by Utah 2001 gives a kind of semi-quantitative score of the severity of cardiac impairment in fetal heart failure. This score uses the items high drops, yes or no, and where is there pericardial effusion, pleural effusion, or situs, venous Doppler, heart size, cardiac function, and the Doppler of the umbilical artery. So our case, so normally we have about 10 points in the normal fetus, and our case has hollow systolic tricuspid regurgitation, so 10 points minus 1 are 9 points. Then our patient had ascites and pleural effusion, so 9 minus 1 are 8 points. Has negative A waves in the venous duct, so minus 1 is 7, and also a heart size about 0.5 heart area to chest area. So again, minus 2. So about this patient has a CVPS of 6 or 5, and this is really poor. So poor prognosis if this cardiovascular profile score is less than 7. Finally, this neonate was born and died due to necrosizing enterocolitis 3 weeks after birth. Was ductal dependent. So this is the next case with severe right ventricular dysfunction seen in 22 plus 1 weeks of gestation. And this fetus also had functional pulmonary atresia, reverse flow in the duct, pericardial effusion, endocardial fibroelastosis of the right ventricle, and also pulsative umbilical veins. On M mode, in 28 plus 2 weeks of gestation, the fetus showed this pattern. This is the right atrium, this is the left ventricle, and obviously the left ventricle has a faster rate than the right atrium. So this fetus had ventricular tachycardia with a ventricular rate about 218, an atrial rate about 143, and due to fetal hydrops, a cesarean was performed. Postnatally, this neonate showed severe biventricular impairment and very low contractility. And if you observe this 4-chamber view, you can see that ventricular and atrial rate are different. So this is one of the ECGs this neonate got. It was AV block 2:1 with extrasystolis or not. And then the nurses observed that this neonate had a funny ECG on the monitor, and they didn't know what it is. So they made an ECG, and this is the funny ECG the nurses saw on the monitor. Torsade points with therapy. And obviously, this fetus had a long QT syndrome type 2 with the AV block 2 and torsades, right ventricular cardiomyopathy with pulmonary stenosis, and was put on beta blocker and later got heart transplantation. So in fetal dilated cardiomyopathy, we always have to think on familially dilated cardiomyopathies, Uhl's disease as primary myocardial disease. And this is a very nice case of Sally Klür, who shared this picture today. And you see the very, very thin skin-like tissue or myocardium of this right ventricle in a fetus with Uhl's disease. Other primary myocardial disease can be non-compaction, metabolic disease, and stages of primary hypertrophic cardiomyopathies. And again, myocarditis can result in dilated cardiomyopathy. Now, a case of restrictive cardiomyopathy. This is a case seen in the 36 plus 4 weeks of gestation. And a cousin of this case had hypoplastic left heart syndrome. And we saw biventricular hypoplasia of small ventricles with endocardial fibroacistosis, large atria, poor contractility, and the neonate was delivered, and postnatal course was very stormy and did not survive. This is the Doppler of the venous duct with high pulsatility. So what are the risk factors for poor outcome in cardiomyopathy? This is a study, quite old, but interesting data. And if there's a dysfunction of both ventricle, and if there is a diastolic dysfunction or a holosystolic regurgitation of 2 valves or more, then the risk of fetal demise or postnatal demise is quite high, especially in AV valve regurgitation. A more recent paper of the Toronto group also published the risk factors for poor outcome in cardiomyopathy and showed that a CVPS score less than 6 or about 6 and hypertrophic cardiomyopathy shows a significant higher risk for fetal and postnatal demise. Here in this figure 2 are in red the cases who died, and in blue those who were alive. And on the x-axis there is the cardiovascular profile score. These are the fetuses who survived the first month, and these are the children who survived the first year. And it's clear the blue lines are higher than the red lines in those fetuses with a CVPS score above 6, so 7 to 10. Also, this Kaplan-Meier plot shows nicely, that freedom from death or cardiac transplantation was higher in the non-hypertrophic cardiomyopathy group than in the hypertrophic cardiomyopathy group. So what is the diagnostic workup? First of all, we have to screen for extra cardiac causes, high output renal disease, diabetes. Take carefully the family history, index case male, do parental ECG or echocardiography, genetics, maternal infections, if there's any sign for this, or antibodies. You may take also amniotic fluid if you want to do so. Repeat the fetal echo, do cardiovascular profile score, and plan delivery. When, where, how, and take care that you are able to have material from the umbilical blood for further diagnosis. So the take-home message is fetal cardiomyopathy is a rare disease, mostly found in dilated forms. The prenatal diagnostic work today is a little bit limited, but we have to exclude secondary causes. Assessment and follow-up is necessary, and mortality is high in hypertrophic cardiomyopathy and low CVPS. Thank you for your attention.
Thank you, Ulrika. Beautiful talk. And I don't have any questions. Oh, there is one here from Dr. Singh again. How to differentiate tricuspid regurgitation caused by dilation of the right side of the heart versus dilated cardiomyopathy?
You can do the DPDT measurement, and if there is a high DPDT number or gradient, then it's a sign for good ventricular function. And the question is, why does the fetus has a tricuspid regurgitation? In both cases, it's not normal.
100%. So the answer is that, I mean, with dilation, you get that the valve itself goes, but if there is a dysfunction in the tricuspid valve, the morphology would look different, definitely. Maybe we can ask Dr. Silverman also to add to this. Dr. Silverman, are you still there?
I'm still here. Of course, I'm still here.
Okay.
I just wanted to compliment Dr. Herbig on a wonderful talk, beautifully articulated and illustrated. But I have a question for her. And my question for her is, right ventricular non-compaction has been described with left ventricular non-compaction. I've never seen it described per se. And I don't know how you differentiate this. Is there any histological evidence that you've got or specimen that has shown actually a hypertrabeculation after birth?
So this
even in the fetus?
In the fetus, there was no MRI done. And postnatally, we did an MRI on this case, and we saw the trabeculation mostly on the right side. But we all know that this can change, and we have seen that in the initial, let's say, ultrasound images, we sometimes in the neonate or small children, we don't see the typical features of non-compaction, and later it will be more clear. So you are right. I also made the note that isolated right ventricular cardiomyopathy per se has not been described yet. Yeah.
So the thing that was interesting about this case is that as the child developed, it all disappeared. And I think we know that non-compaction runs a sinusoidal course, a sine wave course. And so this may occur at a later stage, but it would be interesting to follow this child later and see whether you can accumulate any other patients. I wonder, is Anita still there?
Yes, Anita is there.
I'm still here.
Anita, what do you think?
I think there's so much we don't know about non-compaction. There is a paper that I worked on with Deepak Srivastava looking at a particular family that had right ventricular non-compaction and atrial septal defects. The non-compaction was not symptomatic, but I have seen, it isolated and not, at least the phenotype not being evident in the left ventricle, but only in that setting. So I think also, though, that it's difficult to diagnose in the fetus. Sometimes non-compaction looks like hypertrophy if your lateral resolution is and your frame rates are not optimized. And so we may be underdiagnosing this non-compacted phenotype in the fetus.
Well, I mean, my biggest problem, and I'd like to ask you that now, I mean, I don't mean to put you on the spot, but how do you differentiate hypertrophy from non-compaction in the right ventricle? Because the right ventricle's natural response is a response of trabeculations. It's a trabecular ventricle. So how do you differentiate? I'm asking the same question of both of you. And what I want to know is, how do you diagnose right ventricular non-compaction? I have a specimen with left ventricular non-compaction and right ventricular non-compaction absolutely evident. But the only reason you can say that it's right ventricular non-compaction is because there's left ventricular non-compaction.
Mm-hmm.
And the other question that one has to ask about this disease, of course, is it, if it's a genetic disease, which it seems likely to be, especially with the Bath syndrome, et cetera, is there a likelihood that this is a total myocardial disease? And of course, is this a cardiomyopathy? And this is a big fight, not only in the neonate and the fetus, but also in adult life.
But you're also, I was sure that you're going to ask this question, because remember when we reviewed the cases that with the non-compaction antenatal diagnosis paper, I asked you the same question about RV non-compaction, and you said it's rare. But what Aureka is showing is that they recovered postnatally. So this is perhaps against diagnosis or not against diagnosis?
I don't know the answer. I think it's hard to discuss on one or a few patients what the syndromic things is. I mean, with the Bath syndrome, but that was a different patient. But with Bath syndrome, I think that's easy. But without Bath syndrome, it's not that easy to call that a genetic disease.
What is the gold standard?
I think what we're going to find in the upcoming years, as whole exome and whole genome sequencing is used more and more, that it's going to be more important to describe the genotype, because the phenotypes of all of these myocardial problems are going to be quite variable.
Well, I think that's a brilliant point that you just made, and it's a general point. I mean, I think that whole exome sequencing will be great. The problem is, if you look at the isomerisms and you look at whole exome sequencing in isomerism, it's not just one gene, it's a whole slew of genes that is involved. And I don't know that, that when we get to the genetic data, that the phenotype is an expression of a whole group of genotypes. I mean, I think from the COVID that we've learned that, with the inflammatory syndrome, that the body has only got a certain limited ways of responding to badness. And it could be that it looks very much like Kawasaki disease, and maybe that's why Kawasaki disease has got that phenomenon that there is a cytokine storm that goes on, just as an example of a generic thing for a body. And this may be the case for the non-compaction and for isomerism. I think it's a general problem in medicine.
You're trying to say, Dr. Silverman, indirectly, in answer to Anita's question with the whole exome sequences, that perhaps we will not be able to know what information we're getting from that to pinpoint which disease and which, because I'm not sure with the whole exome you can know which is which. It might give us an idea, but it will not pinpoint which, this because as you showed with the isomerism cases, how many genes were responsible for only one lesion?
Yeah. I think that Anita's point is correct. I think that it will give us information, but it may not, in our current state of understanding the future, give us the answers that we can now use with the tools that we have. I think that, the tools are certainly becoming phenomenal. When you consider CRISPRs and that sort of thing. We don't know where the end of genetics is. We're just looking at it, especially myself, from the beginning of the tunnel. And I can't even see the light at the end of the tunnel, but I'm sure that there are other more enlightened people that have got better answers than I have for this.
Very, very interesting discussion regarding the genetics as well. Also with the extracardiac, going back to your, before we leave the non-compaction, Dr. Silverman, what is the gold standard of diagnosis of non-compaction? Because lots of things going on, and you will send it to MRI, and then yes or no, or perhaps. What is the gold standard, in your point of view, a practical and easy way?
If I have to put my MRI hat on, MRI is the gold standard of everything. But I think that from my point of view, it's well enough recognized in fetuses and in small children by means of ultrasound. I think it's, you know, you don't find patients that have no MRI evidence of what we would call hypertrabeculation, and those that do. And of course, in the hypertrabeculation issue, there are papers now where in adults, a huge number of people on MRI have been diagnosed with what they call non-compaction, which is probably a terrible term, but that the ventricles are hypertrabeculated, and the hypertrabeculation may be from other responses, but it also may be a response from cardiomyopathy. My colleague working with Anita and I says he regards hypertrabeculation only as a disease in the presence of cardiomyopathy.
So if their echo is saying there is a non-compaction and the MRI says no or possible, you go with the MRI and ignore the echo.
I personally wouldn't, because I'm an echocardiographer, but I think that that situation rarely occurs. I mean, you're proposing me a hypothetical situation, and in that situation, you have to trust what you know. I've seen this happen time and time again with my mentor, Dr. Rudolph, who always asked for a cardiac catheterization because he could understand the hemodynamics and the physiology and the angiography. Okay, an echocardiogram was strange to him. And I feel the same way about looking at MRIs. I trust the echocardiogram because I understand it, and I'm not liable to overinterpret this condition. So, and that says circumstance that you propose, I would trust the echocardiogram, but it's only because I think that your hypothetical situation is almost non-existent.
Thank you. One last question to Anita. In the registry that you've kindly showed, did all countries or all centers follow the same entry criteria? Selection?
No. The criterion for entering a patient into the registry was that you did the intervention, but we do not prescribe any kind of criteria. We're collecting the information from people. So for instance, I mean, you know, most people would say multiple gestation would exclude a patient, but there are some places that that didn't consider that an exclusion. It was fairly uniform. What appeared to be the criteria are fairly uniform for aortic stenosis. But this is what I was trying to bring out, that because we don't say only enter the patients who have a Z-score of this and who, you know, we were trying to collect information in a different way. So if they did the intervention, then we collected the data. But we do have fetal echo data and postnatal echo data that we're starting to be able to analyze. One of the biggest drawbacks of the registry is that it doesn't have actual images in it, only the measurements and interpretations that were done by the center that was entering. At the time that we set up the registry, now remember this is 2009 to 2010, it was very difficult to get information because of patient privacy laws and because they're so different in different countries. Very hard to get images because of the potential that they might contain identifiers either on the image or in the metadata of the images. And it seemed to be a regulatory hurdle that we were not going to be able to cross. So we don't have the actual images, but you know, we can trust, I think, that the fetal centers, Ulrika is the lead at her center, we have to trust that she can actually measure an aortic valve and say if flow is left to right or right to left. There's a certain degree of, yes, it would be ideal to have a core lab, but we're talking about experts here, not not people who don't know what they're doing.
Rika, do you have anything to say regarding what Anita just said, the entry criteria and the registry? Because you've been long in it as well.
So we enter the data, and we it's very easy. So we do the follow-up, and sometimes we would like to enter more information because it is not so this has maybe to be changed, but otherwise, so it's easy to be done. And I think it's very important because you now, with this database, you get information not only from a single center, you get the real data, the real worldwide data. That's important.
Thank you very much. Again, back to the same question. I'm sorry we forgot to answer him, Dr. Singh. How would you know the difference between RV, which is dilated secondary to tricuspid valve disease, versus cardiomyopathy? This is to Dr. Silverman.
I'm sorry, I wasn't paying attention. Ask that question again, please.
This from Dr. Singh. How would you differentiate between the dilation of the RV secondary to cardiomyopathy versus tricuspid valve disease?
I don't know the answer. Firstly, I can't hear you very well.
Okay, I'm sorry. Well, I should shout. The difference between cardiomyopathy, RV cardiomyopathy versus RV dilation secondary to tricuspid valve disease. So how would you know the difference? This is cardiomyopathy, but what's the etiology? Is the dilatation?
I'll tell you what I do. I do this on a regular basis. I ask Anita. So what do you say, Anita?
I think Ulrika already tried to answer this. One thing that you can look at is the DPDT of the tricuspid regurgitation jet. Another, just looking at the myocardium, and then a third would be to look at the outflow. So if the pulmonary valve annulus is normal size and there's a good VTI, normal right ventricular output, then you can have quite a bit of tricuspid regurgitation. If, on the other hand, the right-sided output is low and we're seeing a imbalance of right ventricular to left ventricular output in the wrong direction, so that is that the output is shifting to the ventricle, then that might suggest that the right ventricle is not just having a tricuspid valve problem. Of course, if you have Ebstein's malformation, for instance, I consider Ebstein's not to be a valve disease. That is it's a global disease, and the right ventricle does have a myopathy there. So with Ebstein's, that's not necessary to tell the difference because they all have both. But if you just have isolated tricuspid valve regurgitation, these are some of the things you can look for. And then also finding another reason for the tricuspid regurgitation. Most of the time, isolated tricuspid regurgitation, if the valve is normal, is going to be due to ductal constriction, and so that would be obvious from the rest of the echo. So you have all of these different tools.
Okay, thank you very much.
Not that I want to belabor this very difficult point, but in adult mitral valve disease, often the ventricle looks like it's functioning very well until you go and replace the valve and stop the AV valve regurgitation, because when you do that, you then force the ventricular myocardium to contract against a much higher afterload. And so I think it's a very complicated point, because there are patients that get valve replacement that look like they've got good function as adults, and you put in a valve and all of a sudden they've got very poor myocardial function because the ventricle's loading conditions are changing. And I think that's one of the problems that we have, just looking at this very difficult question, providing a reasonable answer to it. I mean, we can give some kind of an answer, but whether we actually solve the issue is not clear.
Okay, thank you very, very much. A beautiful answer, a bit difficult to grasp. Thank you very much. Thank you all of you for all the speakers, and for our attendees, and for Sasha and Grace and Congenital Heart Academy. Would like to thank all of you for staying 2 hours and more with all the information. Everybody's saying thank you, thank you, thank you, and we hope to see you again in the future.
Just one last thing. I see Grace and Sasha are not answering, but I'd asked this before, that we sign off to the attendees and tell them that if they go to the website, the URL website for what's that thing called?
Hi, Dr. Silverman. Yes, I placed it on the chat box, the link for the YouTube channel of Congenital Heart Academy, so everybody can review all the talks there. Thank you for that.
Okay, on YouTube is the word I was looking for. I'm sorry, I'm getting old.
Yes.
But it's all
you
on
are
YouTube,
not.
and I must tell you that I go back and look at all of these again, because I learn so much more of the little nuances that I've missed. And it's a tremendous resource, because all of the talks that have been given there are on there, and you can actually spend, it's like going into a library. You know, you can spend the whole day there. And I must say, that's a really remarkable achievement of the Congenital Heart Academy. Thank you.
Thank you. Thank you very much, Norman. Thank you. We are very happy. I think this is going to be the legacy of all of our speakers. You know, their knowledge are going to be able to be seen for a lot of people who were not able to see live on the webinar. So we are very happy for that, to provide this education all over the world. And we hope that we continue with that. And thank you all for this the first of our fetal series webinars. We are inviting all of you to be with us every month to talk more about fetal cardiology. Thank you, guys.
Thank you. Thank you all.
Thank you.
Nice to meet you, Ulrika.
Thank you very much.
Goodbye, Sasha.
Goodbye. Thank you.
Bye, Grace. Auf Wiedersehen.
Wiedersehen.
Bye-bye, guys.
Bye.